Obsessive-Compulsive and Related Disorders. This video will be presented by Maria, Zafrah, Angela, Gabriella, and Sara. The outline for this presentation is the following. The background section will include definitions, followed by some brief history and statistics. Next, the characteristics and symptoms of the disorder will be explained, along with the potential causes and risk factors for developing OCD. After that, the choice of a non-medication treatment will be discussed. Then, the method, results, and critiques of 2 studies will be examined. And finally, examples of how this disorder is portrayed in the media will be given, along with an explanation of what stigma contributes to. A majority of this presentation will specifically focus on obsessive-compulsive disorder, but will also touch on the related disorders as well. Obsessive-compulsive disorder, or OCD, is a mental health disorder that affects people of all ages and occurs when there is a presence of obsessions, compulsions, or both. This condition can be so disabling that back in 1990, the World Health Organization ranked OCD as one of the top 10 leading causes of disability in the world in terms of loss of quality of life and loss of income. In fact, it was also suggested that OCD was the 5th leading cause of burden for women in developed countries. Most of the historical records of OCD descriptions are in religious literature rather than medical literature, as in the 14th and 15th century, obsessional fears around religion were common. Around this time, scrupulosity, which involves religious obsession, was a word that was used to describe obsessions and compulsions. The name obsessive-compulsive disorder did not come into being until the 20th century. The classification of obsessive-compulsive disorder continues to be redefined, as it used to fall under the same category as anxiety disorders. However, the Diagnostic and Statistical Manual of Mental Disorders, or DSM-5, has recently added a new category called obsessive-compulsive and related disorders. This category includes disorders with obsessive preoccupations and repetitive behaviors, including the familiar obsessive-compulsive disorder, hoarding disorder, excoriation disorder, body dysmorphic disorder, and trichotillomania. As youth, young males are more likely than females to experience OCD. However, by adulthood, this changes and women are slightly more affected than males. About 65% of individuals develop OCD before the age of 25, and only 15% develop this disorder after the age of 35. Individuals with OCD often suffer in silence and will either not tell anyone about their disorder or not get any help at all due to stigma and shame. This makes it difficult to determine exactly how many individuals experience obsessions and compulsions. It is estimated that 1 to 2% of the population has OCD or will have it at some point in their lives. DSM-5 defines obsessions by 1. The individual experiences recurrent and persistent thoughts, urges, or images that are intrusive and unwanted. In most cases, this causes anxiety or stress. 2. The individual attempts to suppress and ignore the thoughts, urges, or images, or tries to neutralize them with another thought or distraction. This could be done by performing a compulsion. DSM-5 defines compulsions by 1. An individual will be driven to perform repetitive behaviors or mental acts in response to an obsession or according to rules that must be rigidly applied. Or 2. The aim of repetitive behaviors and mental acts are to reduce anxiety or distress or prevent a dreaded event or situation. However, the behaviors or mental acts are not connected to what the individual is trying to neutralize or prevent in a realistic way and can also be seen as excessive.
Characteristics and symptoms of OCD and related disorders run on a spectrum or continuum, similar to that of autism. This means that each individual may not experience all symptoms, in that the defining characteristics range in severity on a case-by-case basis. OCD can be difficult to treat, as it is often found in individuals with associated mental health issues, such as substance abuse issues, anxiety, or depression. OCD compulsions differ from typical rituals and habits in that they are extremely disruptive and interfere with day-to-day activities. They do not bring satisfaction to the individual, and they consume a large amount of time in each day. Other disorders related to OCD have unique identifying characteristics, but all involve the motion of obsessive or repetitive thoughts and behaviors. Characteristics of OCD are uniquely categorized and defined by obsessions and compulsions. Obsessions refer to repetitive thoughts such as constant fear of germs or contamination, frequent forbidden or unruly thoughts about illegal or negative behavior, aggressive thoughts towards oneself and others, and constantly seeking symmetry, order, and pattern. Compulsions refer to the repetitive behavior themselves, including excessive hand-washing, organizing, rearranging things, repeatedly checking things that are already turned off or unused, and obsessive counting. Additional symptoms or effects that can arise from OCD are vast. They include things such as general distress. This may range from physical, emotional, mental, financial, or even legal distress. Additionally, individuals with OCD are often reclusive and show signs of isolating themselves or seek reassurance from others. These effects, including distress, often involve and affect family members or loved ones close to the individual, as OCD can be a consuming and difficult disorder for all those involved. Characteristics for other OCD-related disorders vary. For example, hoarding disorder includes difficulty letting go of possessions and anxiety when discarding possessions or when others touch their things. Excoriation disorder refers specifically to the uncontrollable repetitive act of picking skin until it causes lesions that is unrelated to any underlying physical or dermatological issue. This often occurs in times of stress, and the individual has made repeated efforts to stop, but is unable to. Similarly, trichotillomania refers to individuals who compulsively and uncontrollably pull out their hair as a form of relief. Lastly, body dysmorphic disorder occurs when an individual is extremely preoccupied with their perceived negative bodily flaw, and they have an extremely strong belief that others have a negative outlook towards them solely based on this perceived flaw. This individual makes repeated efforts to fix, modify, or hide the flaw, often through surgical or cosmetic means. A specific outlook in this disorder includes muscle dysmorphia, which is when an individual who is usually male has an obsessive outlook on their muscular flaws and performs repetitive, compulsive, and consuming behaviors to alter their appearance. There are no known causes for OCD. However, there are identifiable risk factors that increase an individual's likelihood of developing the disorder. Many risk factors for OCD-related disorders are very similar to those of OCD, given that individuals exhibit the same kind of uncontrollable behaviors. Body dysmorphic disorder is particularly impacted by environmental influences, as an individual's outlook on themselves is sometimes affected by society and their peers. This means that external factors such as social media influences, peer pressure, child abuse or neglect, and growing up in an environment that is not nurturing or does not promote self-love may particularly trigger the onset of OCD or similar disorders, such as body dysmorphic disorder. As such, prolonged or significant stress and trauma are known triggers for a variety of mental illnesses, including OCD and related disorders. Primarily, genetics play an influential role in the onset of OCD. Twin and family studies show that an individual is more likely to develop OCD if there is a first-degree relative, meaning a parent or sibling in the family that already has the disorder. Additionally, further genetic research is ongoing to determine if there are any other genetic factors that play a role in OCD development. Brain structure and function are other aspects that influence OCD development. Research shows differences in the frontal cortex and subcortical structures of the brains of OCD patients compared to those without the disorder. There are also neurochemical abnormalities that have been identified that may contribute to OCD development. Lastly, environmental impacts may have a significant influence on OCD development. Individuals who have been physically or sexually abused, especially during childhood, are more likely to develop the disorder. Furthermore, traumatic events or particularly stressful incidences have been known to trigger OCD development or worsen the obsessive thoughts and compulsive behaviors in individuals who already exhibit OCD characteristics. Alternatively, it has been reported that some may develop OCD following a streptococcal infection. This relationship is called pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections, or PANDAS.
There are different types of treatments for OCD. However, cognitive behavioral therapy is a non-medication treatment designed to assist patients who have conditions such as OCD. Up until the mid-1960s, OCD was considered treatment-resistant since psychodynamic psychotherapy and medication were unsuccessful in lessening the symptoms associated with OCD. Cognitive behavioral therapy is a treatment method in which patients are exposed to anxiety-provoking stimuli while refraining from participating in their compulsive behaviors. With significant long-term exposure to the stimuli, patients become accustomed to anxiety, which results in new learned information that is not compatible with the distorted belief and behavior. Cognitive behavioral therapy also helps identify distorted beliefs and the reasons why these behaviors are compulsive. There are different stages a patient will go through when receiving cognitive therapy with a therapist. The first step of cognitive therapy involves patients developing an understanding of their compulsions, worries, and obsessions. Patients may be asked to keep a diary, which is known as thought records. This diary is meant for patients to log daily thoughts and behaviors throughout their treatment. In the next step of cognitive therapy, therapists will review the thought records and challenge the patient by addressing the unhealthy beliefs, allowing the patient to understand the distorted thought behind the obsession. Lastly, behavioral experiments are performed to disprove the compulsive behavior or thought. For example, an individual with OCD may repeatedly check on their loved ones to make sure that they are safe. With cognitive therapy, the therapist will ask the patient not to check on their family members as frequently to disprove the fact that the family's safety is at risk without frequent checkups. Over time, the patients gain the ability to reevaluate their beliefs and change their behavior accordingly. After identifying and understanding that these thoughts and behaviors are unhealthy, an individual with OCD can better control his or her thoughts and behaviors throughout the treatment process.
The first study we will explore is the predictors and moderators of cognitive and behavioral outcomes for obsessive-compulsive disorder, a patient-level mega-analysis of 8 sites. The study focused on determining the effectiveness of behavioral and cognitive therapy as treatment options for OCD patients. It used data from 8 participating research clinic centers to examine the benefits of cognitive therapy, behavioral therapy, and cognitive behavioral therapy combined. From the different treatment sites, a total of 359 participants were included in the study, of which 125 received behavioral therapy, 108 received cognitive therapy, and lastly, 126 individuals received a combination of cognitive and behavioral therapy. And all of these participants were assigned to a total of 12 therapy sessions. The results of the study indicate that the 3 different therapies contributed to a significant reduction in obsessive-compulsive disorder symptoms and depression symptoms amongst these patients. To determine the results, T-test, Yale-Brown Obsessive-Compulsive Scale, and the Beck Depressive Inventory were used. Continuing on, the Yale-Brown Obsessive-Compulsive Scale was the primary outcome measure and was used before and after the intervention. This test includes a total of 10 questions, and based on the scores the participants received, therapists were able to determine the severity of their obsessions and compulsions. As we can see, the scores before the intervention ranged from 23 to 25, meaning people had moderate to severe OCD, and after the treatment, the scores dropped down to 8 to 15, meaning mild OCD. In addition to that, the clinics also utilized the Beck Depression Inventory. This test consists of 21 questions regarding depressive feelings. For this test, we can see that the depression went from mild depression to minimal depression amongst the patients. So overall, the cognitive behavioral therapy along with behavioral therapy are extremely effective in reducing OCD symptoms. Critiques for Study 1. The abstract was well structured and was very informative as it explained the purpose of the study and summarized it in detail. As for the method, the study was quite feasible because the researchers had an easy access to data from pre-existing studies. Also, since they used data from 8 different sites, they had a lot of information to put together. This allowed the method to be well detailed. There was no mention of ethics approval of the studies that were used, but since the researchers used published studies, it can be assumed that they received an approval because in order for studies to be published, they require an approval from the ethics community. Results and discussion. The researchers talked about the limitations they faced during their analysis and even provided some recommendations for future research. Overall, this study did a great job in determining the effectiveness of cognitive and behavioral therapy for OCD patients. Another study determined the effectiveness of cognitive behavioral therapy, but focused only on the Internet-based CBT for patients with obsessive-compulsive disorder. This study recruited 23 patients aged 21 to 67, and they received Internet-based cognitive therapy. Just like the previous study, the study took baseline measures of Yale-Brown Obsessive-Compulsive Scale and took scores after the intervention. The secondary outcome were self-rate measures, so individuals had to recognize and note down their depressive anxiety symptoms, general functioning on these assessments. A total of 6 self-rated assessments were used, which included Montgomery-Åsberg Depression Rating Scale, Penn State Worry Questionnaire, Global Assessment of Functioning, Quality of Life Inventory, Internicola, and Obsessive-Compulsive Inventory. All the tests, except for Quality of Life Inventory and Penn State Worry Questionnaire, showed a significant improvement in obsessive-compulsive disorder symptoms amongst the patients after the intervention. This intervention led to a 61% clinically significant improvement amongst all patients, and 43% of them were no longer categorized under the diagnostic criteria of obsessive-compulsive disorder. Critiques of the study. The researchers got their study accepted by the ethics community in Stockholm and even provided participants with consent forms. They recruited patients that were diagnosed with obsessive-compulsive disorder from different backgrounds and ages, which allowed the study to be more inclusive of all people. Although the study was very well written and did miss out on important details, the study did have some room for improvement. They excluded individuals with severe OCD, and this could have affected the generalization of the results. The assessors were not blinded throughout the study, which could have caused biased results. And lastly, since this was a pilot study, it did not have randomization, and it makes it difficult to claim that the improvements were solely caused by the internet therapy sessions the patients received.
A character that some people may be aware of that portrays characteristics of OCD is Alan Zaveri, played by Charlie Barnett in the Netflix series Russian Doll. Although this character is not discussed in the series as being formally diagnosed with the condition, it is implied through his compulsive actions and obsession with cleanliness, order, and routine. Due to our lack of access to a video to show you, I'll give you a synopsis of his OCD symptoms seen in the episode. The first scene he is in the show has him at his bathroom mirror finishing brushing his teeth. He puts the brush down and kills a fly on the wall with a roll of newspaper. He purposefully walks to his bedroom and unzips a suitcase filled with very neatly folded clothes. He steps away from the suitcase and asks his Google Home to play affirmations for success. He then repeats the affirmations as he takes things out of his suitcase and lays them on shelves. He feeds his fish, then goes to head out the door. He continues to repeat these affirmations as he walks through the park and seems nervous and jittery. In the next scene, he says, "Routine is an incredible thing. We become what we repeatedly do." He goes to his girlfriend's house and spills his drink, saying, "This wasn't supposed to happen," and furiously wipes it up. She says that his biggest problem is he's always trying to fix every little thing. He later in the episode has a meltdown and leaves his apartment a complete mess. He cleans it up the following morning, straightening all pillows to be completely vertical, makes sure his throw blanket is completely wrinkle-free, and feeds his fish. All of his movements seem purposeful and swift. As with many other portrayals of OCD in the media, Alan shows a very strong aversion to disorder and mess. We see this in the show through his very organized apartment, with minimalist furniture, meticulously folded clothes, and a strict routine he abides by. The character also seems socially inept, having difficulty dealing with and communicating emotions, something that is often seen in characters with symptoms of OCD. As with other popular TV characters, like Sheldon Cooper in The Big Bang Theory, characters with mannerisms indicative of OCD tend to be portrayed as also having a form of autism, or being peculiar and cold. This only worsens the stigma that individuals with OCD are compulsive to the point of constant judgment of others and seeming condescension. While OCD does increase the chances of sudden outbursts of emotion or paranoia, as well as a strict need for routine and seeming lack of control over thoughts, this does not always manifest itself in the stereotypical way of an antisocial personality. This idea only contributes to the stigma that surrounds OCD sufferers as being cold and impersonal because they are too caught up in the details. While this may be the case for some individuals, it is a broad generalization, as most OCD sufferers live normal lives when using appropriate coping mechanisms and may not even realize they have the disorder. The idea that all individuals with OCD are neat freaks is also a common misconception, as some impulses may instead lead to a hoarding situation, which is quite the opposite from the minimalism often shown. It appears that in the media, only individuals with severe OCD are ever displayed, and they share common traits of being awkward, explosive, and particular. While some aspects of this may be applicable, there are too many ways the OCD can manifest itself to make generalizations accurate portrayals of the disorder.